Hi, everyone. Good afternoon, and thank you so much for joining us today. We're so glad that you could all log in and hear a little bit about the implications of COVID-19 and our adult Duchenne population. We recognize that this is a unique and higher risk subpopulation within the Duchenne community, and so we look forward to hearing a little bit more about that today. To start off, I have really exciting news today. Just here a couple of hours ago, we announced the certification of Kennedy Krieger Institute as the second adult certified Duchenne Care Center, as well as the first dually certified center within our network as both an adult and pediatric certified Duchenne Care Center. So this is really exciting news. This is the first time we've had this dual certification, and we're just really proud of everything that the team at Kennedy Krieger is doing. And so we're really excited to have some team members from the Kennedy Krieger team speaking with us today. So as we can see here, our lineup for our speakers today, we have Dr. Catherine Wagner, who is the neurologist and director of the dually certified center at Kennedy Krieger, as well as Dr. Jonathan Finder, a pulmonologist at Le Bonheur Children's Hospital and a longtime friend of the organization as a board member as well. And then we also have Dr. Andreas Barth, a cardiologist at Kennedy Krieger. So at this time, I'll go ahead and hand it over to Dr. Catherine Wagner to talk about some of the neurologic implications of COVID-19 and adults with Duchenne muscular dystrophy.
Well, hello. I hope you are all well, both physically and mentally. It is certainly a really difficult time for everyone, especially those with chronic diseases. Let me start talking about prevention. So for a variety of reasons, immunosuppression, cardiac disease, respiratory insufficiency, those with Duchenne are considered high risk. So you should be limiting your contact with adults with Duchenne. Household members should ideally be working at home, not going into work, not socializing, washing their hands frequently, disinfecting services. If the visiting nurse or aide is absolutely necessary to come into the house, then I would recommend that person wear surgical masks and gloves. Secondly, I'd like to talk about adrenal insufficiency. For those who are on corticosteroids, be aware that they almost are certainly adrenally suppressed. And this has several implications. First, if they get sick, and they are on every other day steroids or weekend dose steroids, they should switch to daily steroids. They don't need to do this now, but if they get sick, they should switch to daily dosing. They should contact their doctors for higher or stress dose steroids. And although it's not proven, there is some thought that hydrocortisone given 3 times daily is more helpful for stress dosing than daily prednisone or deflazacort. Vomiting occurs in a minority of patients with coronavirus infection, but one should be prepared for that possibility and the possibility that you can't keep down your daily corticosteroids. So every family with an individual with DMD should have intramuscular Solu-Cortef at home, ready to go. I would recommend that you get this ahead of time and not wait for your family member to be sick. And this is delivered into a large muscle, such as the deltoid or thigh. And again, this is only if they can't keep down their daily corticosteroid from continuous vomiting. I think you'll get some more information about home management if the individual becomes sick with coronavirus from Dr. Finder. But let me just put in my 2 cents, and then he can go into this more. I think you should take Tylenol for a fever. I would recommend that you increase your cough assist to every 2 hours. Shortness of breath should be carefully monitored with help from your pulmonologist. and an O2 sat less than 94% likely warrants going into the emergency department. You should call ahead if you're going to do that, and wear a mask. If you are hospitalized, be aware that the Office for Civil Rights in the U.S. Department of Health and Human Services has issued a bulletin to ensure that there is no discrimination on the basis of anything: race, color, national origin, age, sex, including disability. So, as such, persons with disability should not be denied medical care on the basis of assessing any quality of life, judgments of the person's relative worth, presence or absence of disabilities, etc. It's important to provide your health information to the emergency department providers, including any alerts. This includes, for example, that no oxygenation should be given without ventilation. I would recommend bringing your own BiPAP, which may not be allowed in normal circumstances, but under the current shortages of equipment, I think it likely will be. Remember that succinylcholine and depolarizing neuromuscular blockers are often used for muscle paralysis during intubation, but these are contraindicated in Duchenne. They can lead to massive rhabdomyolysis, cardiac arrhythmias, and death. Patients with Duchenne also have an increase in time of onset and prolonged response to non-depolarizing neuromuscular blockers when compared to unaffected individuals. And so I would actually recommend that a Duchenne individual be intubated without neuromuscular blockade, which has been shown to be safely done in the past. So I'm going to turn it back to the moderator, but I'm staying on to answer questions at the end of the webinar.
Great. Thank you so much, Dr. Wagner. That was really helpful information. At this time, we're going to hear from Dr. Jonathan Finder, who is going to talk about pulmonary implications and different ventilatory equipment needs that we might see and have to think about in the case of an infection with COVID-19. Dr. Finder?
Hi, everybody. So, first of all, I want to talk a little bit about the use of the Cockatrice device, and I think I can advance the slide, but let me see if this works. Yes, it does. And when I use the term Cockatrice, I'm talking about any of these devices that are on the screen here. Hillrom makes one called Vital Cough, and there's one called the Nippy Clearway, which is in Europe, and there's two models of a Cockatrice device shown here. And they all do the same thing, which is push air in and pull it back out again. And I want to talk about two things. First of all, that if you have a device like shown, it's really good to have two settings, a healthy and a sick setting. And I'm going to walk you through why you need each. The concept of the healthy setting is referred to as lung volume recruitment. That means stretching the lungs open, and it's also called air stacking, and it prevents what's referred to as atelectasis. That's a word that means collapse of the lungs inside the chest, or volume loss. And what we take for granted is our ability to yawn and sigh, where we take a very deep breath and fully expand our lungs and stretch our chest wall muscles. The muscles between our ribs are called the intercostals. And in order to stretch those muscles, you need to be able to take a deep breath. And by the time you're an adult with muscular dystrophy, you're not going to have a full capability. So take a nice, very deep breath can be done very easily with a Cockatrice device. And that can be done several times a day to keep the chest wall limber and prevent rigidity or stiffness of the chest wall, but also can pop open areas of the lung that might have some partial collapse because of mucus. And so that typically you would have settings where you would turn the expiratory time off, you turn the expiratory time to 0, and then you just give a nice deep inspiration of around 2 or 3 seconds. The pressure don't have to be too high, anywhere 30 to 40, which for comfort. And again, you can figure it out by adjusting it to comfort and figure out what it takes to get a nice deep breath and a sort of a short breath hold. And 2 or 3 seconds should be sufficient in terms of doing it. I know it wouldn't go beyond 3 seconds. And then you can wait 2 seconds and do about 5 sets of 5 breaths twice a day. That's my usual healthy setting. And I have found that patients don't mind this at all. A lot of kids hate the cough assist device because the feeling of having the air pulled out of their chest is uncomfortable. And so if you don't have any secretions to clear, this is probably adequate for keeping your lungs healthy. And so I really advocate for everyone to do this on a regular basis. The mode in which you want to clear the airways or to help with coughing is where you want to turn the expiratory time on. And typically I'll put the positive pressure in between 35 and 40. The negative pressure phase, it was the pulling the air out phase of negative 35 to negative 45, and usually about 2 seconds per cycle. The exhale or exsufflation phase is added in for the cough, for the airway clearance phase. It's very, very helpful if you have a cold, and we'll talk more about the concept of this infection. And the question is, how often do you use this? And I'm going to disagree with Dr. Wagner just a little bit here, which is that you use as often as you need to. In other words, when someone says to me, how often do I use this? I say, well, how often do you have to cough? Sometimes you're coughing every 5 minutes. Sometimes you're coughing every hour or every half an hour. Whenever you have to cough, you use it. And you literally cannot overdose on this device. As long as it's set up properly, using for a few minutes at a time, you're not going to hyperventilate someone down until they pass out. And you can always give someone a break if they're sort of feeling lightheaded. So use it as much as you need to. Don't hold back on it. Better to use it too much than too little. So let's talk about COVID-19. It causes a viral pneumonia. What that does is it makes your lungs stiffer and harder to inflate, and therefore it increases the work of breathing. And so it also, because it makes the lungs stiffer, the oxygen doesn't get through as easily. And so monitoring your son's saturation is incredibly important. And so every person who has a cough assist device really ought to have a pulse oximeter. And if you don't have one right now, they're very, very easy to obtain. You can get one on Amazon. You can get one at the local Walgreens. They're not very expensive. The Fingertip pulse oximeters. If your saturation is persistently below 95%, that's a cause for concern, and at the very least call to your doctor, and more likely a visit to the emergency room. We've already discussed the importance of isolation and doing your level best to keep folks at home. The nice thing about, not nice thing, but one important thing about having muscular dystrophy is that you're not going to be as likely to have hand contact with infected surfaces. But those around you who touch you may have issues with that. So hand sanitation for caregivers is incredibly important, more important than ever. And keeping the patients home and isolated is also really important. And for literally decades, I have talked about the importance of getting out and doing stuff and getting out of the house. This is the one time it's important not to get out and do stuff and to stay home. So what else? Let's see. Let me go back to my next slide. Sorry, that's my last slide. So, I'm not going to give a lot of advice about in-hospital management because that's really, the doctors are going to be in charge of that. But I will say that I'm happy to talk to anyone's doctor if they have questions about management of respiratory failure, and that if you have a BiPAP machine at home, I agree with Dr. Wagner. You definitely want to bring that in because there's going to be a shortage of ventilators, and that the nice thing about having a BiPAP machine is you have the ability to turn the pressures up a little bit, and it's possible that a person with this infection will need a lot more support. And can they be managed at home? Well, you don't want to take too many chances. And so if that device is not meeting your child's needs, your son's needs, then you really want to have him seen, because what you don't want to do is you start playing with the machine and not knowing if you're adequately breathing for him. And we can't get blood gases and CO2 measurements in the home. All we can do is measure saturation. So I would say need for oxygen equals need for hospitalization. And I'll end there, and again, I'll stay on the line and be happy to answer questions.
Wonderful. Thank you so much, Dr. Finder. That was really fantastic. A lot of just great practical advice to keep in mind and have these things on hand and in the front of our minds as we go through this really scary time. So at this point, we're going to hear from Dr. Andreas Barth, who is at Kennedy Krieger Institute and is a cardiologist. So he's going to share with us some different considerations for Duchenne and the heart in COVID-19.
Perfect. Thank you very much. Good afternoon to all listeners. I want to thank PPMD for putting together this webinar. I know that in this time full of uncertainty and social distancing, having the right information is certainly vital, and hopefully we can convey the message that we're here for you, and providing the right information will hopefully also reduce anxiety. Now, I was asked to answer two main questions. The first one is to give an overview of the implications of COVID-19 for patients with heart disease, and specifically to see whether does COVID-19 affect the heart at all, and if so, in what way. And secondly, we prescribe a lot of medications that are common in heart failure, and particularly in patients with Duchenne, like ACE inhibitors. And there has been a lot of uncertainty and media coverage whether it's safe to do so in patients who are at risk of COVID-19. Now, the first question, whether COVID-19 can affect the heart. And we know that SARS-CoV-2 that's the virus of the disease causing COVID-19, is part of a larger group of respiratory viruses that are known to cause epidemics, particularly in the winter months. And the most common virus that is known is influenza. And we know from influenza that it not only affects the respiratory system, but it can, in a substantial percentage of patients, also affect the heart. I recall very vividly a patient who was treated in the ICU earlier this year who had influenza B and who developed myocarditis, which is an acute inflammation of the heart muscle. And it was a 48-year-old man, previously healthy. And the myocarditis, the acute inflammation of the heart, was so severe that it led to severe heart failure, and actually he required cardiac life support for a couple of days until that recovered. In addition to acute inflammation of the heart muscle, influenza can also lead to a pro-inflammatory state that can lead to an increased risk of heart attacks or myocardial infarction. I'm sorry, that's the slide. And what do we know about cardiac injury with COVID-19? Well, this is hot off the press. It was published just last week. Coming out of Wuhan, which was the epicenter of COVID-19 until very recently in China. And they examined 416 patients at a hospital in Wuhan, and they looked at a cardiac biomarker, which is called troponin I. And this is a muscle protein that's involved in cardiac contraction that's also released to the bloodstream when you have an acute inflammation of your heart muscle, or when you have a heart attack, for instance. And they were able to measure this cardiac troponin I in patients who had COVID-19, and they found that about 20% of those patients with COVID-19 had elevated troponin I levels. And not only was it elevated, but this was relevant because it correlated with prognosis in this patient, and it did so in a quite dramatic way. When you look at patients who did not have elevations of troponin I, this is indicated here by the blue line, they had actually a 30-day survival, which was more than 90%, more than 95% of those patients survived if troponin I was not elevated. However, those patients where troponin I was elevated, they had a much higher chance of dying. So 50% of them died by 30 days. And the question becomes, well, did they die because they had heart involvement? Or was the heart involvement just a reflection of the fact that those patients were particularly sick? And I think this is what we can see from that data. When you look, what kind of complications did those patients with COVID-19 with and without cardiac injury develop, is that patients who had ARDS, which is the severe form of lung injury that is seen with COVID-19 and with other forms of viral pneumonia, that affects both lungs and leads to severe inflammation and ultimately also scarring of the lung. if you had ARDS, you were much more likely to have cardiac injury. So 60% of patients, nearly 60% of patients had elevated troponin I markers, whereas patients who, without elevation of troponin I, had a much lower chance of having ARDS. So those patients were were less sick. Likewise, patients who had kidney injury with electrolyte disturbances were also much more likely to have elevations of their troponin I. And there was also a statistically significant association with hyperproteinemia and coagulation disorders, which are proteins that are synthesized in the liver. So there was some degree of liver dysfunction. So if you had liver dysfunction, you were also you were sicker and had also a higher rate of cardiac injury at the same time. The next interesting question is to ask, well, do those patients who contract the most severe forms of COVID-19, do they have anything in common? And the answer is yes. They had a higher rate of pre-existing medical illnesses, chronic medical illnesses like hypertension, which was nearly 3 times as common in patients with cardiac injury. They had, it was in 60% of patients versus 23% of patients without cardiac injury. Likewise, if you had diabetes, you were twice as likely to have cardiac injury than without diabetes. And there was also a higher rate of coronary artery disease, coronary heart disease, cerebrovascular disease leading to strokes, and heart failure as well. And all those chronic medical illnesses are diseases that we usually see in an aging population. And indeed, those patients at higher risk of cardiac injuries were older. They were 74, and those without cardiac injuries, they were a little bit younger. And this is also what we know from the data, not in China, but in the U.S. alone. There was data based on CDC from mid-February until mid-March. We know that age is probably one of the most important risk factors when it comes to do you develop complications from COVID-19. And the blue bars show the percentage of hospitalizations. The red ones are ICU admissions, and the green ones are the risk of dying from COVID-19 in percent, and that's according to age. And you can see that there's a clear correlation with age. The older you are, the higher the risk of having more severe forms of COVID-19 that would require either hospitalization, ICU admissions, or even risk of dying. Now, I know that most of our Duchenne population is younger, but you cannot necessarily say that the risk is lower because a lot of the comorbidities, a lot of the illnesses that increase your risk of COVID-19 complications are actually higher in our Duchenne population, like heart failure, like diabetes, obesity, and also immunosuppression from chronic prednisone use. The second question that I would like to address is whether the medications that are commonly prescribed to treat heart failure in the setting of Duchenne, which are ACE inhibitors like lisinopril, perindopril, ramipril, or angiotensin receptor blockers, ARBs like losartan, valsartan, irbesartan, are they safe, or do they increase the risk of contracting COVID-19? And the reason why we're discussing that is that the ACE inhibitor that are used to treat heart failure, they block the ACE1 enzyme, and that's an enzyme that generates angiotensin 2, which is a molecule that can lead to worsening heart failure. So blocking the ACE1 enzyme with ACE inhibitors and angiotensin receptor blockers downstream has been shown to be very beneficial for the heart. Now, one of the unintended side products of blocking the ACE1 enzyme is that you get upregulation of the enzyme called ACE2, which is different from the ACE1 that's cardioprotective. And ACE2 is expressed also in the lung, it's expressed in the heart, and it has been shown to be the receptor that is necessary for the COVID-19 virus, or for the SARS-CoV-2 virus, to bind to human cells and it's sort of the key that's required to entry into the human body. And there are some concerns that if you have an increased level of ACE2, whether that increases your risk of contracting COVID-19. Now, it's important to stress that these are all preclinical data in animal models that have raised some concerns, but at this moment, there is no data to show that the same is true also for humans, for patients. And there are really no studies to show that if you take ACE inhibitors, if you take angiotensin receptor blockers, that this really significantly increases the risk of COVID-19. In fact, all our major societies have released guidelines within the last week to say that you should absolutely stay on those medications and that premature discontinuation of those medications can lead to worsening heart failure and worsening hypertension, higher rate of myocardial infarction, and ultimately clinical instability. So the recommendations right now are clear to stay on those medications, and you should not prematurely stop them because that may theoretically increase your risk of COVID-19. Now, at the very last slide, I want to just show how would we treat from a cardiologist perspective patients who have COVID-19, and particularly in patients who have Duchenne and have heart failure that's either clinically apparent or that's subclinical. And I want to group that in three phases. So what do we do first if you contract the disease and it's very mild? You're either asymptomatic or you have a very mild cold, which most patients have. And in that case, we also do not recommend to discontinue, to stop the ACE inhibitors or angiotensin receptor blockers. They should be continued. If you have fever, we say, well, the fever should be treated. And if you treat it more with Tylenol. Do not use NSAIDs like ibuprofen. There was also a lot of discussion whether there is an interaction with ibuprofen and COVID-19. And I think ultimately that has been resolved or it's being investigated closer. That's not the reason why we as cardiologists do not recommend NSAIDs, but we know that ibuprofen and other NSAIDs, they lead to more fluid retention, to sodium retention, hence our recommendation to avoid those as fever-reducing agents and to use more Tylenol if possible. Now, if you have a form of COVID-19 that's more severe, that requires you to have to be hospitalized, in that case, we actually do recommend to hold the ACE inhibitors and the losartan if the blood pressure is low, and your treating physician at the hospital will likely do that. One important aspect is if you're hospitalized, if you go to the emergency room, one of the first things that they usually do is they hook you up to an IV fluid. And it's important to know, even with subclinical forms of heart failure, it's important to bring it to the attention of the physician if it's not a cardiologist familiar with treating patients with Duchenne, to use IV fluids rather judiciously and not at a high rate, because that can precipitate volume overload. And it's very likely that at that stage, once you're hospitalized, they will check all those serum markers that we previously discussed in this publication from China, the troponin or other biomarkers that show how healthy your heart is, and likely an echocardiogram will be done at that time as well. And last, if you have advanced COVID-19 disease that require not only admission to the hospital, but likely to the ICU, where you have some evidence that the heart is involved more profoundly, that you have heart failure, you may need medications like adrenaline, like derivatives to keep the pump function going of the heart. And there are also some considerations whether this profound inflammation that is encountered at that stage, whether there's any use of giving medications like very high doses of prednisone or other anti-inflammatory drugs to help with the disease process, but we really don't have enough evidence for that at this moment. Well, I want to stop there and we'll be happy to answer any questions.
Great. Wonderful. Thank you so much, Dr. Barth. That was really wonderful. So at this point, we're going to go ahead and shift to our question and answer session. We've already got several questions that were submitted in advance that we'll go through. And I see many of you have already been utilizing that chat box function in the lower left-hand corner of your screen. If you have a question and haven't submitted it through that function already, please feel free to do that now. And we'll go ahead and just dive right in. So one thing that I know we've been talking about a little bit internally at PPMD that's really started a lot of conversation, and maybe Dr. Wagner and Dr. Finder, you can dive into an answer with this. You know, if we do find ourselves in an ER and we're concerned about being discriminated against because of a baseline disability, what are the best ways that we can advocate for ourselves? What are some of the things that we can say? How can we be successful in advocating to make sure that we're not discriminated against because of disability during that triage process?
I think that you could cite the bulletin that from the Office for Civil Rights in the U.S. Department of Health and Human Services has put out. It is available on the HHS website, and say that that there are laws to protect your loved ones from discrimination based on disability.
Fantastic. Okay, great. All right. So the next question we have, and Dr. Finder, fair warning, most of these are pulmonary, so get ready. But our next question is, how important is it, given the warnings about the vents and a full face mask spraying virus into the room, is it to have a closed circuit on the ventilator if you are COVID positive and recovering at home?
Well, again, you're not going to be changing the circuit on your ventilator. It depends on if you're on a trach versus a BiPAP, and so they have different. You really don't have a choice in changing your circuit. So your circuit's going to be open or closed depending on whether it's, for example, if you're on BiPAP, it has to have a release on it. And so the concept is that I don't think in the home the Duchenne patient is the risk to others. Others are the risk to the Duchenne patient. And so obviously a person who has COVID-19 is not going to be, ideally would not be caring for a Duchenne patient. And it is an issue because if you have one caregiver and that person gets sick, what are you going to do? And you're going to have to think of a contingency plan for that possibility, which is why it's important that the caregivers really take good care of themselves and really are careful about not having any unnecessary exposure to other people right now. So I would say that this is not necessarily going to be a problem, and that a person with muscular dystrophy is going to be is going to have less chance of having COVID-19 because of less hand contact with services. On the other hand, whatever bed support they need, they're going to have to get.
Great. And a bit of a follow-on question. So this is another question for you, Dr. Finder. One of the folks on the call said that she was on a webinar yesterday with another physician, and they said that hospitals are discontinuing PFT labs due to the risk of spreading COVID. Are you seeing this in your institution or in colleagues' institutions?
Yeah, so there have been a lot of chatter about PFT labs, and it's because of two things. The risk is high to respiratory therapists because they are asking people to exhale very forcefully, and there's going to be a lot of virus in the air. And so we are not doing PFTs on anyone with suspected viral infection of any sort. We do the occasional lung function test on a case-by-case basis. We did not close our lab, so we're doing the occasional lung function test on as needed. But generally, I'm not doing it on a person who's infected. And my techs are wearing, masks and gowns and gloves. and we're sanitizing the equipment as best we can. We're also doing as much testing in the patient's room as opposed to in the lab. So we have portable equipment, so we can test patients if they need to be tested in their exam rooms. So we've done that, and also in the hospital rooms as needed. So I mean, we can't stop doing X-rays as well, and so those are done portably, and for that matter, EKG. But we have to sanitize the equipment afterwards.
Okay, great. And this next question is about the flu shot. I believe this is from our friends in Australia. I know we're towards the end of flu season here in the U.S., but should we get the regular flu shot right now if that's what our government is recommending?
Absolutely. I mean, what you don't want is another illness that potentially could lead to a hospitalization and then potentially a secondary exposure. So whatever we can do to stay healthy, yes. So should you get a flu shot? Absolutely. That's the easiest question of my day.
I liked that one, though. I love easy answers, right? It's nice when we can tackle those ones. All right. So the next question we have, if you have access to an IPV machine, whether at the hospital or at home, will the HF waves exacerbate the immune response to the virus, causing greater secretions and inflammation, or will it do what it is designed to do and remove debris and inflate the alveoli simultaneously?
There's very few Duchenne patients that have an IPV. Stands for intrapulmonary, IPV is intrapulmonary percussive ventilation, and there's very few of them out there. So this is probably just one person on the call who might have one. And I've never used one for muscular dystrophy. It's been used in the hospital with pneumonia. So the concept is an IPV basically is, it's kind of like I call the vest from the inside out. It shakes your lungs and loosens secretions. There's no evidence that the device is pro-inflammatory. And so if one were in the hospital and you had a bad pneumonia, one could think about using it. On the other hand, COVID-19 is not a bacterial pneumonia. So viral pneumonia, it doesn't give you a lot of secretions to clear. We didn't talk much about that. But if you look at all the literature about COVID-19, it's a dry cough. And so there's not a lot of secretions to clear. And so I don't think that IPV will be helpful for this particular infection, first of all. So it's kind of a non-issue. Secondly, almost no one has one. So secondly, not a big issue in our Duchenne patients. It's been used in cystic fibrosis. And we could talk about that in another conference call when we do a CF. But I would say that if you take the same question about Cockatrice's device, I'd say that if it's helpful and the person has some secretions, you should go ahead and use it. Bear in mind, IPV does not help you with cough clearance. It helps you with mucociliary clearance. It helps shake loose secretions, but it doesn't evacuate them from the lungs. That's why it does not replace a Cockatrice device.
Perfect. And you actually segued quite well into the next question as it relates to the Cockatrice machine. So since COVID-19 does cause this dry, non-productive cough, should it even be used, or could it even cause more harm than good through irritation or inflammation?
It's not going to cause harm because coughing itself doesn't cause harm. And the forces used by Cockatrice device are far less than the normal forces generated by a healthy adult without muscular dystrophy. So there's no risk in using the device in normal settings. And so you shouldn't fear using it. It really comes down to if a person has some secretions that need to be cleared, then by all means, clear them, use it. If a person, I would imagine that having viral pneumonia would put you at higher risk for developing some areas of collapse or atelectasis, volume loss, and so at the very least, the lung insufflation mode will be helpful. So I would say that you could certainly use it on the lung insufflation mode, which in my slides means turning off the expiratory or exsufflation mode, and I think that will be helpful. I don't think it will be harmful. On balance, I'd be more in favor of using it than not using it.
Okay, perfect. That was really helpful. All right, so this is another question about ventilator support, so definitely a common theme that we're seeing. So should adults with Duchenne work with their neurologist, internist, pulmonologist, whomever, to seek the use of ventilator support earlier in the infection cycle? For instance, a Duchenne or Becker person who suddenly has fever and cough, it may or may not be COVID-19 and maybe has about 80% lung capacity when healthy, but may not be able to properly breathe or cough at home, even with the cough assist. What would you recommend as the approach in that sort of situation?
As a pulmonologist, I would say that if your baseline lung function is normal and your saturation is normal, then I would say then you can use your saturation as the gauge for how much to worry. And so if a person tends to be saturating in the high 90s and no problems, I would say if you feel short of breath, that it's hard to breathe, and if you have low saturation, get seen. That healthy young adults even have had respiratory failure with this virus. And so having normal-ish lung function doesn't mean that your muscle strength is normal to sustain during a severe pneumonia. So I'd have a lower threshold for getting seen. But I'd say if a person feels well and breathing comfortably, even in the presence of fever, I wouldn't necessarily go into the emergency room. I would say that if you have make sure you have a pulse oximeter so you can measure your saturation. If the saturation is high and the breathing is comfortable, do not go to the emergency room. But if your saturations are persistently low, then get seen because you likely will need oxygen and hospitalization. If you're struggling to breathe, by all means get seen, or you can call an ambulance.
So I have my own question about the pulse oximeters. I know that isn't necessarily something that everybody already has at home. So if a family does not have it at home, what would be the best way to go about getting one? And do you feel that it is incredibly pertinent to have one? And it sounds like that part is probably a yes. But how would we get one if we needed one?
Oh, you can get them online. You can go on Amazon and do a search for Fingertip pulse oximeter. They're relatively inexpensive. They're maybe $20 a piece. And I think it's a good investment to get one. And I know that they sell them in the larger chain drugstores like Walgreens and such. So they're easily obtained. You don't have to have a hospital quality one, and you can always check it on yourself. But I think everyone right now who has a somewhat muscular issue ought to go out and get one.
Yeah, I've found with my patients that a lot of the pharmacies are sold out of them, but I have heard that Amazon still has them.
Thank goodness for Amazon Prime. All right. Next, I have a question.
I was going to
go ahead.
I was wondering if you could bring up a question that I've received from patients.
Absolutely. What do you got?
Apparently, some people are going out and getting hydroxychloroquine or chloroquine, and I would recommend against this. And whether you got it when you were hospitalized or not, I think is a very difficult decision. But again, I don't think that the benefits outweigh the risks. There is data on both that they cause myopathy, and I've actually published on severe myopathy that can occur where a previously a ambulatory patient lost the ability to walk. I think that in the absence of our knowing for sure that these drugs are helpful in fighting COVID-19, I would recommend against using them in the Duchenne community.
I
think that's really helpful.
I would agree.
Go ahead, Dr. Barth.
The myopathy can also lead to cardiomyopathy, so to weakening of the heart muscle. This is usually a chronic effect if you take it for a month or years, but it can, in the short term, lead to electrical instability. It can lead to arrhythmias. So in the absence of definitive data to show that this is really an effective medication, I think it should only be used within clinical studies, but not widely distributed at this moment.
And I would even encourage folks on the line, if you have more questions about this, that was actually a topic that we covered on last week's webinar about medications and Duchenne and COVID and all of these implications, particularly the concern of lengthening the QT interval in someone who is taking chloroquine or hydroxychloroquine combined with azithromycin. I know a lot of folks have seen that recommendation or consideration on the news and in articles. So I would encourage you to go back, take a listen. We do have that archived. It's available on YouTube. You can link it through our website. We had a great conversation with a couple of cardiologists, and we're able to dive a little bit deeper on that topic as well. All right, so let me see. What else do we have here? Lots of really great questions. So here's one about BiPAP and ventilators. So a lot of our adult guys have BiPAPs at home already. Perhaps some of them are already ventilated either at night or 24/7. What would you recommend about bringing those devices to the hospital? Are there any concerns with bringing those to the hospital? Would you recommend that they be brought to the hospital? Maybe some general commentary on that topic.
Well, Dr. Wagner already mentioned that you should bring your own device because there are likely going to be shortages. And so absolutely bring your own device to the hospital. And the question is that going to be enough? There's a limit to how much you can do with the non-invasive ventilation. If someone's very sick, they're going to get intubated and be put on invasive ventilation. So, but I would say that at the very least, short answer, yes, definitely bring your device to the hospital. And for that matter, bring your own cognizant device to the hospital because you just don't know about what the hospitals have. What you don't want to be is caught short because you didn't bring your device. So bring all your equipment.
Perfect. I love it. All right. So the next question is about breath stacking. Should we do breath stacking with a Cockatrice device or with an Ambu balloon or any other sort of assistive device?
If you have a Cockatrice device, that's going to be a much easier and more comfortable way of doing it. So certainly that's the way to do it. If you don't have a Cockatrice device, and not everyone has access to one, and especially outside the United States, you can certainly do it with an Ambu bag. But I think breath stacking is important. Again, breath stacking is another term for lung volume recruitment, and it's also been referred to as hyperinflation. All these terms means fully inflating the lungs to pop the lungs open. And yes, I definitely strongly advocate for that.
Great. And while we're talking about lung function, again, Dr. Finder, so many of these are right here for you. But this next question is about ventilators. So if someone's already on a ventilator, should they consider changing those settings if they get sick by maybe increasing pressures, or how should they go about making those sorts of adjustments?
In general, we don't want people changing their ventilator settings in the home without direct supervision under medical guidance. And so if the settings you're on are inadequate to keep your son breathing, he needs to get seen. You can't get around that. And it might be that they can adjust him in the emergency room and send you back home again. But there's a good chance you might need to be in the hospital because again, it depends if it's non-invasive versus invasive. And the literature about the non-invasive ventilatory support in COVID has generally been that for the non-muscular dystrophy patients that it's not been that helpful. That they really need to go on vents, and so because these pneumonias are so severe. So I would say that if you feel that your vent support's not doing it, get seen.
And this question is kind of along the same lines of that, and I think you might have the same recommendations, if your concerns can be seen. But for a lot of our guys that have BiPAPs at home, there's a lot of talk out there about being able to essentially convert that BiPAP machine to a ventilator. How can our guys do this, and if they can, should they?
A BiPAP machine is a ventilator. There's no converting. I mean, it's a mode of BiPAP is a mode of ventilatory support, and so you can change if you have a Respironics trilogy, you can change the mode, but that can't be done in the home. That has to be done under medical supervision. That can be done in the hospital. So, but do not think the BiPAP is not ventilatory support. It is. It is a ventilator. That's just a form of it.
Absolutely. I appreciate that clarification. What do you think about, with this dry cough, would it be helpful to use nebulizers, whether it be saline or a prescription nebulizer?
So the hospitals have been trying to avoid nebulization because it causes aerosolization of the virus, because there's some backflow into the nebulizer. And so in the hospital, we've been trying to use immunodose inhaler therapy for albuterol administration as much as we can. In the home, where it's not quite the same of an issue, I don't think of this as necessarily an illness that causes bronchospasm unless you have asthma. And so it's a pneumonia rather than an asthma exacerbation. And so I suspect for the majority of patients, it's going to be unhelpful to give nebulized treatments. And for a minority of people who probably have some predisposition toward asthma, the addition of albuterol would be helpful. And ideally, you would give a immunodose inhaler with a face mask, I should say, or a spacing device. But if you have a home nebulizer and you're in the home environment, I would say that it's probably reasonable to use it. We've just been trying to avoid it in the hospital because of the fact that we worry about nebulizing virus.
Wonderful. Thank you so much. All right. Next up, we have a question about fever treatment. So is there any validity to the assertion that nothing should be used to reduce low fever unless it spikes, because fever plays a role in fighting the virus? If yes, what temperature range should be left alone, and at what temperature level should we consider treating with Tylenol?
So I'll take that one. I actually saw that question ahead of time, and so just ran it by an infectious disease specialist who did not believe that fever was that helpful in combating the virus. So I would recommend that you just take Tylenol to make you feel comfortable. I don't think that there is a particular temperature that needs to be called as a threshold. However, if you have persistent fevers above 102, despite taking Tylenol, that would be worrisome, and you should definitely seek medical help for that.
Great. I appreciate that. I didn't realize that there was that, specific level of 102 that would be a good threshold to consider having to go in. So that's really great. All right. So we get a lot of questions about younger people generally seeming to have less severe symptoms of COVID-19. So is the thinking that it's solely due to having a more robust immunity, or is there some other reason that younger people tend to fare better? The follow-on question to that is, people with Duchenne and Becker on long-term steroids have resulting immune suppression, so that use advantage may not be there to kind of help offset that compromised cardiopulmonary function. So what are your thoughts on that?
Well, I can start. It's a really interesting question because if you think about three things: seasonal flu, H1N1, and coronavirus. Seasonal flu, which comes every year, tends to kill mostly people over age 65. The H1N1 epidemic of 2009 and 10 was unusual in that it killed mostly people under age 65. Coronavirus is, in one sense, behaving like a seasonal flu in that it tends to kill the elderly over 65, but because the death rates are so high, it's right now between 1% and 2% case fatality, that it's also killing a lot of young people, even in disproportionate numbers, even though the majority of deaths are in people over 65. And so the question is, why is it so much harder on the elderly? And I think it's in part the robustness of the immune system in fighting off the virus, but also I think that what young people have and old people do not have is a respiratory and cardiac reserve. The concept of reserve is in other words, if you lose lung function, do you have enough to sustain you? And so a person who's 22 with great normal lungs can lose half their lung function and maybe not be uncomfortable at rest. obviously they're not going to go for a jog. And the same thing is true for cardiac function. If you have, because we know that the cardiac muscle cells can be invaded by the coronavirus, and so I think that if you're losing cardiac and lung function, and you're young and healthy, you can sustain some loss of function without problems. Muscular dystrophy patients already have impaired cardiac function, and they already have impaired lung function, so they have harder. They have less to lose, and therefore much higher risk. And then they're also, because they're on steroids, they're immunocompromised. So I think that we should think of our Duchenne patients as falling into that over 65 category of higher risk.
Okay, thank you so much. All right. It looks like we're starting to get near the end of the questions, which actually works out quite nicely with our time in the hour. So my next question is, would air conditioning potentially create a favorable environment for COVID-19 to survive, since it seems that it survives better in a colder environment? I'm not sure that we have a specific answer there.
That's a no, because the virus itself, it's not that it survives. A viral particle is not a living thing. And so if you are in warm or cold, the virus that lives a certain amount of time on the surface, or Liz or Seb would say, is viable for infection before it begins to break down. Air conditioning, and it's not about the temperature. It's really about the person who it gets to. So I don't think the temperature of the room makes any difference in terms of how infectious this disease is.
Okay, great. All right, and it looks like we'll make this our last question. Can I use steam inhalation with Vicks to help me keep my son's airways open? Do you think that that's something that could be helpful?
I'm strongly opposed to that. Vicks vapor rub is it's a neurotoxin. It contains camphor, which is a known neurotoxin. In my opinion, that drug should be illegal and should not be allowed to be put on any person, healthy or sick, because it is absolutely of no value. It does not keep the airways open. It gives you a false sense of having your airways open, because it enhances the sense of flow by activating the cold receptors in the nose. In no way does it help lung function in any measurable way, but it has, every year someone has a seizure as a result of use of this drug. And so I am very opposed to this product.
That's really helpful. I learned something new myself today. All right. Well, I think at that point, we'll go ahead and we'll stop with questions for now. It looks like we were able to cover, maybe not every question explicitly, but we were able to really cover a lot of the themes that we saw emerge from the questions that were submitted. As I mentioned, this is recorded. This will be available on our website shortly, as well as on YouTube, if you'd like to go back and listen again, along with our previous webinars, including the general COVID-19 and Duchenne webinar, as well as the webinar from last week that took a deeper dive into medications, both prescribed, experimental, and over-the-counter medications. So at this point, I will go ahead and wrap things up. Thank you to all of our speakers today. This was really helpful for us to really keep in mind planning and considerations and things that we need to think about. And of course, everyone, please, please, please stay at home as best you can. All right. Thanks again, everybody. And this concludes today's webinar.